Good morning, and thanks for listening to Aorta Hub today. I'm Jordi Martorell, head of the Group of Vascular Engineering and Allocated Biomedicine of the Chemical Institute of Sarria in Barcelona. I met Dr. Evangelista while I was beginning to establish my research team, and due to his influence, I transitioned from studying flow in carotid and coronary arteries to focusing on the aorta. I partnered with him to implement my engineering models to better understand the development of aortic aneurysms in individuals with Marfan syndrome, a project that we actually published in 2020, but this was in 2015. When I joined Dr. Evangelista in the management of patients suffering from dissections, he proposed that we use the same models we were employing for aneurysms to assess which dissections required surgical intervention and which did not. That was the moment I experienced the shock, It was a life-changing shock for me professionally, and as an engineer, I couldn't understand why a hole in the main artery of our body, the aorta, wasn't being addressed. Dr. Evangelista said that current treatments are suboptimal and that sometimes it's best to do nothing for the patient. Therefore, I decided at this time to begin to work on the development of an endovascular patch to repair aortic dissections. I will present part of this work. And one of the first concepts that I learned was that researching a medical device was key. The most optimal way to secure the funding I needed was to start a company, and if the research was successful, I could commercialize the device and compensate the costs of developing this special medical device. So it was in October 2018 that we founded Aortyx, the company leading the research I present today, where I serve as CEO and General Director. Currently, we have a team of 20 dedicated employees working to deliver our invention to patients suffering from aortic dissection. As you know, aortic dissection is treated in three ways, either through open repair or via endovascular repair, or through medical therapy. Open repair, which involves replacing the damaged segment of the aorta with a polymer tube, is highly invasive, with surgeries lasting between 3 and 8 hours, involving a sternum rupture, utilizing extracorporeal circulation, and lowering body temperature to 22 degrees for brain protection. Such extreme conditions, as you know, cause high perioperative mortality and also lead to long periods of hospitalization and recovery. Created in the 90s, the endovascular repair technique is minimally invasive and employs polymer-coated stents to restore blood flow via the true lumen. Despite its reduced aggressiveness and perioperative mortality, its use remains limited 30 years later due to significant reintervention rates and side effects caused by the complex geometry of the aorta, with a combined incidence of stroke, chronic renal failure, paraplegia, heart failure, and other side effects approaching 25%. We will discuss the reasons later. And medical therapy ultimately remains reserved for patients who are either too fragile, where surgery would be a death sentence, directly, or in those for whom dissection has no severe clinical effects in the short term and a more conservative option is preferred. However, mortality rates in the short and long term are already very high, since in no case is the pathology treated and only pressure is attempted to be reduced to lower the risk of rupture. Considering all this, the RESA study, led by Dr. Evangelista, is consistent with the findings from numerous countries, shows that for type A dissection in the ascending aorta, the repair rate is predominant, with 85% of cases treated this way. While surgical techniques and emergency workflows have improved mortality rates, patient recovery is often slow and painful. The issue is that in the ascending aorta, there is no healthy area to place the stent without obstructing the coronary arteries. This significantly restricts endovascular options to anecdotal instances. The industry is making great efforts to increase eligibility with personalized devices, with branches, with windows, with in-situ adjustments made by the surgeons to address those dissections we previously referred to as type not A, not B, with long-term effectiveness that is still to be evaluated and with a currently very limited option. As we noted earlier, in open surgery patients, there is a sure risk of death especially in those cases where surgery is a guaranteed risk. Pharmacological therapy is tested, primarily beta blockers. ACE inhibitors can almost be considered palliative treatments for elderly patients. In the descending aorta, type B dissections present a completely different scenario. The incidence of open surgery has significantly reduced over the past 20 to 30 years, leaving around 10% of cases and with the prospect of continuing to decrease. Thus, endovascular repair and medical therapy compete to be the first option, having doubled endovascular options in 20 years. As per the guidelines, stents must be placed in complicated dissections, specifically those that exhibit poor perfusion, rapid expansion of diameter, and pain. Uncontrolled hypertension, but in other cases, those wrongly called uncomplicated, a more conservative option is recommended. At the outset, patients are treated solely with pharmacological therapy, placing complete trust in patient monitoring, aiming to stabilize the dissection over time. At each vascular surgery meeting I attend, there's ongoing debate about the quality of these recommendations, and views remain fixed. A very recent meta-analysis involving 25,000 uncomplicated patients, published by Mati Jaburi in the Annals of Vascular Surgery, indicates this. From 2025, it shows increased mortality at 1, 2, 3, and 5 years with medical treatment compared to TEVAR, but there are still no randomized studies of sufficient size today to fully consolidate that position. If we combine cases of type A dissection versus type B, using the known ratio of 2 type A dissections for every type B dissection, we find the following situation, which shows that, unlike the trend in all cardiac and cardiovascular applications, such as TAVIs, foramen ovale, and left atrial appendage, the endovascular treatment of aortic dissection stands at a pitiful 13%, influenced by medical treatment, where open surgery is evidently the preferred choice at 60%. Certainly, we can all concur that by 2025, this is nearly a statistical anomaly. So let's first review why endovascular stents, also known as aortic TAVR, are not adopted more widely. One major reason TAVR is not adopted more is its geometric limitations. Essentially, a covered stent is just a stiff plastic tube that is tightly fitted against the aorta using a nitinol mesh. The aorta is also a tube, but it is flexible, curved with branches that supply the organs. Thus, naturally, in the ascending aorta, a stent, however short it may be, can cover either the sinotubular junction or the innominate artery or both, and in the arch, it can block the supraaortic branches. Complex. In the descending aorta, blocking the left subclavian is quite simple, as this 2021 article illustrates, which indicates what happens if we block the subclavian without revascularizing. In reality, the majority of type A dissections take place in zone 0, while type B dissections occur in zones 2 to 3, with the risk of blocking coronary arteries or the innominate artery when treating the ascend aorta being 100%, and it is 25% in type B injections. This risk is the main limitation for adopting TAVR in aortic design. But there is more, because in recent years, evidence of cardiac side effects due to purely mechanical phenomena has gained significant strength. The classic fundamental role of the aorta is to distribute blood, but it encompasses more than just that. In reality, the most crucial role is to absorb the energy from the cardiac pulse and mitigate the propagation of that pulse. When a stent is implanted, it significantly changes the mechanical properties of the aorta. Metal and plastic are orders of magnitude less flexible than the aorta, so the cardiac pulse wave is no longer absorbed but propagated downstream of the aorta. Thus, we have two phenomena following the stent implantation. On one hand, as Dr. Sherif Sultan explains in this 2022 article, the presence of the stent causes the heart to need to hypertrophy due to insufficient reflux to the coronaries, potentially resulting in heart failure in extreme situations. Conversely, downstream of the stent, the hypertension caused raises the risk of developing new aneurysms and dissections. This is very evident in patients suffering from congenital connective tissue disorders. We start the repair and go one after another as we proceed down the flow to place new stents or perform new operations. Additionally, in cases of regular dissection, it contributes to what is known as the new aneurysm, formed by continuous high-pressure flow. From the entrance that initially allows the dissection to escape, it turns into a re-entry communication. Therefore, we can observe extremely surprisingly, but is the reality, right? The best stentors to treat the aorta dissection, and here the camera comes in a bit, but well, you can see in this paper by Lombardi how the theoretically best designed stent for dissections, the diameter of the aorta, grows in more than 60% of cases. Therefore, the primary goal of the stent, which is to prevent aneurysm progression and avoid rupture, is not being met. We are not achieving the final goal of this, and there are more issues. To be concise, retrograde type A dissection is uncommon but very risky, with about 40% mortality, new entry points, and strokes. Infections. In the end, we are implanting tissue and metal for life, which have a limited lifespan and increasing risks of failure and infections over time. Clearly, with this data, it's not surprising that we still debate at major congresses and conferences whether to use just stents. Because of all the limitations we raised, we proposed a total change in how to manage aortic dissections. This represents a real-size dissection, roughly 1 centimeter in width, which is currently treated with a 20-centimeter fabric cylinder and is secured with a metal mesh that presses against the aortic wall. Instead, what we have done is develop a patch that adheres to the aorta. We designed the patch to have the same mechanical properties as the aorta, encouraging tissue interaction and allowing for absorption over time after the dissection is closed. It attaches to the aorta with an adhesive we developed. This is how it works. The patch is navigated through the aorta using a deflectable guide catheter that bends at the entry tear and deploys the patch. Then the patch adheres to the aorta, sealing the leak in the false lumen and stopping the flow through it. The patch is tied to the deployer with blood-soluble sutures that dissolve once the patch is disengaged and the navigation and implantation system is removed, leaving the patch in place, blocking the entrance. We designed and patented the whole system. The patch is attached to the deployer, as we mentioned, with soluble sutures, and we use a specific adhesive that activates with blood to bond with the wall. The litinol deployer has shape memory and resembles a flower. It is responsible for applying pressure on the patch against the aorta. All of this goes, sorry? I went ahead and want to go back. Let's see if I can. Oh no, they won't allow me to record. Well, no worries. Thanks to its microstructure, the patch obtains its biological and mechanical properties. Constructed using the electrospinning method, it features 2 layers. One aligned layer that interfaces with the blood, and another random layer that interacts with the aortic wall. The aligned layer is dense and creates a quasi-2D structure over which the endothelium migrates easily. But underneath, the random structure is porous and 3-dimensional, providing a real optimal structure for the migration of smooth muscle cells that colonize it and ensure anchoring. For the long-term stability of this patch, the material is bioabsorbable with a degradation time we estimate to be about 2 years, so that once healed, there are no risks associated with long-term implants like infections. The only components retained from the patch are 5 radiopac markers, which are slightly visible here. These markers are crucial for visualizing the implantation and tracking the device's performance. We have made the mechanical properties similar to those of native tissue. Both elasticity and viscoelasticity, meaning the capacity to absorb energy, have been fine-tuned to avoid mechanical mismatch between the patch and the device, maintaining the aorta's mechanical function, capturing the pulse energy to prevent cardiac hypertrophy, and also to halt the progression of post-dissection aneurysms. It is the blood pressure in the true lumen that promotes the remodeling of the aorta without the need for a metallic stent to compress the false lumen. We realized during the development of the device that we could not use the current deflectable catheters for our patch because they only have a single deflection, so that when deflecting they hit the aorta, increasing damage from friction against the entry point and also leaving no free space to detach the patch. We needed to create a double deflectable catheter to generate space within the aorta. The initial devices we presented were so well received by doctors that we also patented the catheter, which could be our first product ready for market. We invented various experimental systems to test our prototypes. I'll show you a couple today. The first one is what we refer to as ex vivo hybrid. In this process, we create a full-scale 3D graft using soft resin and replace the implantation site with animal tissue, the graft coils in this case. We connect a piston pump that drives flow from the ascending aorta like a heart, and we can use anything from water to blood or high viscosity fluids depending on what we want to test to try out. We capture footage through a port installed at ground zero using an endoscope, but if the fluid isn't clear, visibility is poor. I'll show you a few examples later on. In these systems, we test the maneuverability of the catheters or the adhesion strength of the patch. And you can see in the video how the aorta pulses, and we have observed that the internal pressure in this aorta is suitable for our tests. This is inside the aorta seen with the endoscope. We deployed it in water to clearly see the unfolding. As you can imagine, in previous interactions with the deployer, the patch deployment was not as good as what we are showing now. However, if you look closely, the deployer expands in millimeters, and its remarkable elasticity is what allows it to revert to the shape we initially crimped it without any deformation. Next, the patch is pressed against the wall of the aorta to ensure it adheres correctly. And here you will see a little thing floating, right? What is floating around here is a plug, okay? Because we need to protect the adhesive from blood during the adhesion of the second catheter, the carrier, and this has a plug that is pushed by the deployer, preventing blood from coming into contact with the adhesive and curing too early. This plug is tied with an ultra-strong fiber, obviously, so it doesn't float away downstream. After 30 seconds, although the usage instructions will actually be 3 minutes, the soluble wear has completely dissolved and the adhesive has polymerized. Now it's time to remove the deployer, and also note that when retracting the deployer, the plug follows and automatically fits inside the carrier. That's why we named it the auto plug. The patch is now adhered and moves with the natural motion of the aorta. We went a couple of kilometers further and tested under wall conditions more similar to those of a patient with aortic dissection. To create the false lumen, we initially cut half the perimeter for improved access to the true lumen. Next, we created the entry door with a biscuiter and then introduced a spatula between the intima and media, approximately as best as we could. And to enlarge the false lumen, the membrane is then sutured to the true lumen to promote the progression of the false lumen. Next, we suture the incision of the middle perimeter and then fill that volume with a mix of metalloproteinases that causes the aortic wall to lose mechanical properties, somewhat in line with what happens biologically in reality. Then we applied flow to increase the depth of the false lumen, and the model was ready to be tested. As you can see, the wall had a more gelatinous texture and was not slippery. This effect was primarily observed under the microscope, with several layers beneath the endothelium. Ultimately, we ran the experiment I had taught you earlier. I organized it, and we accomplished it successfully, truly sealing the whole dissection we had formed. Thus, it acts as a minor proof of concept. We have also conducted experiments on cadavers, animals, and human also, so these cadavers are fresh and random. That is to say, we needed to plan tests for a particular day, and the donor was an individual who died 2 to 3 days before the scheduled test, which we organized weeks ahead. A really handicap. Therefore, we had little control over which donor would show up, and none had actually passed away due to aortic disease. Essentially, we replicated the standard procedure by inserting our catheter through the femoral artery to the implantation site, and the flow was linked through access via the carotid artery, making a complete incision in the femoral artery. The flow then came out through the femoral artery, but not all that entered, as it was partially distributed across the body, resulting in bodies that were really full of water. And despite connecting the flow, the aorta itself was very poorly pressurized, and we never achieved the minimum diameters to implant in the descending aorta. We also tried a different approach by going through a carotid artery to implant in the ascending aorta, as shown in this video. The catheter, the deployer, and the radiopaque markers are clearly visible, represented by these small dots you see here. It was our first implantation in cadavers, and we are very proud of it. We have also recently conducted numerous experiments on live animals. We implanted in 100-kilogram rams, as you can see here. You can observe the implantation of the device, the markers on the patch, and even the plug, which currently has a radiopag marker as well, to ensure that it stays in position. In 3D, you can observe how it maintains its position as we perform the implantation. Later, we observed after 30 days how the patch continues to follow the movement of the aorta. As we stated at the start of the presentation, there is no mechanical mismatch between the aorta and the patch, which leads us to expect that issues related to the stiffness of the strands will not arise again. The radiopag markers, which is an older image, you will only see two markers. They are perfectly visible, as you can see here, by foundation by tag. And during the explantation, it is observed how the tissue has colonized the patch before absorbing it. This image shows the patch 90 days after implantation, and if it looks shiny, it indicates that it has been fully re-endothelialization. We observe at the microscopic level what we patented in 2018 as we began the presentation. The patch is completely reused and smooth muscle cells are migrating and colonizing. We also observe that if we examine myofibroblasts between 30 and 90 days, we can see the maturation of the tissue, leading to more elastin fibers that are better aligned. In the future, we plan to conduct several experiments which will last at least a year to observe the correct patch resorption. EJ key points are that at the histopathological level, excellent biocompatibility is observed with no inflammation, minimal thrombosis, and excellent endothelialization from 30 days post-implantation. We are closing in on the design and expect to begin trials in 2027 with type B decision patients. Clearly, besides aortic dissection, we are thinking about other focal injuries, particularly in the aorta, and our technology can be easily adjusted to accommodate aortic transitions caused by trauma. Hematomas, penetrating corruption, secular aneurysms, and also damage specific to stents such as endoluminal issues or new entry tears caused by the stent at medium term. With this, I hope you found it interesting. Feel free to contact me via email or LinkedIn or however you prefer if you want to know more, or if you would like to participate in our upcoming clinical studies. I would like to thank Dr. Evangelista again for the opportunity and all the listeners who attended. Thank you very much.